Hello, everyone, and welcome to Carolina Breast Friends YouTube channel. We are excited tonight to be discussing genetic counseling and breast cancer with Stephanie Nix with Carolina Healthcare Systems. And it's a pleasure to have you, Stephanie. Thanks for being here.
Thank you. Thank you. So I understand that most of you who are live on the call have had genetic testing previously. Since we are recording and there may be other ladies who would watch the recording, I'm going to do just a brief overview of the genetics and how they relate to cancer. I'm going to talk a little bit about who should be a good candidate for genetic counseling and or testing, and then talk some about positives, negatives. But really, I'm very glad to say that I got some questions from your group. So I've addressed some hot topics in cancer genetics. I welcome any questions that the group may have. Please write those in the chat and we can address them. All right, so most of you already know this. What is a gene? We get one copy of every gene from our mother, one copy from our father. Anytime there's a mutation in a gene, that basically I describe it as a typo, just a change in the sequence of the DNA. Mutations occur all the time in lots of different cells in our body. What we talk about mostly with genetic testing then is inherited mutations. But you probably have heard that there are other types of genetic testing, one in particular that oncologists may order that is somatic genetic testing. So I'm going to review what that is as part of the presentation. So here we see a mutation on one copy of the gene. I've just randomly assigned it from the mother. We know that most of the genes that are related to cancer risk have some involvement in DNA repair. So these genes normally function to repair the damage that's present in our DNA. And depending on the dominant or recessive nature of that gene, one mutation may be enough to have an increased risk for cancer, specifically in this setting, or two copies may be necessary for some traits. There are a couple genes that we test for on our cancer panels that are recessive, and one of those is a colon polyp condition. So, having a mutation means that our risk for cancer is increased. It's never a guarantee, though. So that's an important thing whenever we're talking to our family members about this, about the question of having predictive genetic testing. The test is not going to tell us that you have cancer. It's not going to tell us that you're guaranteed for cancer. It just says your probabilities are much higher than the average person's risk would be, or what your baseline risk was. You probably have heard this before. All cancer is genetic, but not all cancer is hereditary. So the top of our image here, we have the idea of how sporadic cancer occurs. So we have all of our cells present at birth, assuming there are no mutations predisposing any cancer. And then as we age and are exposed to everything in life, it could be, radiation, chemicals in the environment, hormones, whatever it is, all of the things of life and time and aging, we accumulate changes in our cells and the DNA of those cells, and that can result in a cell becoming a cancer. On the other hand, a hereditary cancer, you would have every cell of the body has a mutation in a cancer predisposition gene. And so it takes a shorter amount of time to acquire mutations just because of the environment and randomness to result in cancer occurring. So typically when you see hereditary cancer, you're going to see an earlier age of onset. You're going to see cancers that are more rare occurring. You may see multiple family members having the same type of cancer or related cancers. And we'll talk about that as well. A lot of people are shocked when I tell them this, and it's often one of the first things that I will say to people because a lot of us do have family members with cancer. And so when we go in to have genetic counseling or have a consult over the phone, I like to off the bat tell people, only 5 to 10% of cancer is hereditary. There is a familial component, maybe 20%. Those folks don't have a single gene that has a mutation. There may be multiple genetic factors, but also shared environment. So you can't ever tease that apart whenever it's familial on why those folks do have an increased risk for cancer. And then 70% of cancer is considered to be sporadic, or it's occurring because of environmental factors. You probably have seen a list like this before. The red flags, the things that people talk about. One of the biggest things has always been breast cancer at an early age. Share a little bit about this later on, but there was a change. I think it occurred in September of last year that our national society changed our criteria for breast cancer testing to age 50 or younger, having no other family history, no pathology considered, age 50 and younger. It used to be age 45 and younger. Triple negative breast cancer, though again, that's not the most common type, and you can have inherited types of breast cancer that are not triple negative. So sometimes people will say, but at least mine's not triple negative. That means it's not inherited, right? But you can have all varieties of that. Some other things that we would look for would be 3 individuals with breast cancer, and I'll throw in there prostate or pancreatic, ovarian cancer on the same side of the family. Doesn't have to be 3 individuals, but a combination of those cancers. Of course, male breast cancer, that by itself has greater than a 5 to 10% likelihood that we have a hereditary mutation that's present whenever we see male breast cancer. Ovarian cancer at any age, pancreatic cancer at any age. And then we've thrown in here some of the referrals that we also commonly see. So breast cancer is not the only type of cancer that we see for consideration of genetic testing, though it's definitely the greatest proportion. So we see people that have a personal or family history of uterine cancer, colon cancer, pancreatic, prostate. Those are all pretty common, but you can imagine the more rare cancers too. We may see those because by themselves, their rarity may signal us to do genetic testing. So think something like gastric or stomach cancer. And then if we have a family member who has a genetic mutation that's been identified, or a tumor profile, or what I think of as a somatic DNA test has indicated that there might be a genetic mutation present. It does not have to be in the BRCA gene. It could be in a number of different genes. I've already covered most of this. Also thinking about bilateral or multiple primaries, that doesn't have to be at the same time. So if we have a close relative that has had breast cancer 10 years ago, and then they have a new breast cancer on the opposite breast, for example, that's the same person having 2 separate primaries, that's an indication by itself, no matter of the age, to consider doing genetic testing. For most of you that have been through this, we feel like it's a pretty painless, appointment. They last 30 minutes to an hour is pretty typical. Sometimes it's a little bit faster when we do our phone consults, because we get right to business, because we're asking those questions directly. We're not able to see you. So we ask questions about your personal history, your family history, and specifically related to cancer. I did work in obstetrics, so that's pregnancy care, for 15 years. So I've heard lots of different family histories and information, but we really are addressing in our setting at Levine Cancer Institute cancer history, and maybe also some other blood-based conditions as well, things like inherited anemias, for example. We talk about the benefits, limitations, and risks of genetic testing, and really try to sort out if the person is ready for testing. Are they interested in testing? How might it be useful to their treatment plan or decisions that are being made in the healthcare setting? Anyone who has genetic testing and we find that there is a mutation, and the report says pathogenic variant is the verbiage that you'll often see on these reports. That means that there is a change in the DNA that has already been proven to be related to a cancer risk. Then we would schedule a follow-up visit with our geneticist. So we're very fortunate at Levine to have our own geneticist who just handles cancer risk. Probably seen images like this before, really focusing on that 10 to 15% of breast cancers that we know are due to an inherited mutation. The vast majority of these are BRCA1 and BRCA2, approximately 30% each of all of the inherited varieties. And then looking around the side of the pie, you see the proportion of other breast cancer genes that are commonly tested on our panels that may also be found. Now, each of these genes has a different profile of what mutations you might, what cancers may be at risk based on those mutations. So the PTEN gene is related to a condition called Cowden syndrome, Banyan-Riley-Ruvalcaba-Cowden. We love the names of these all doctors who have discovered these genes. And PTEN can cause breast cancer, uterine cancer, and thyroid cancer. So we may be suspicious of that based on a family history, or we may find it on genetic testing, not knowing much about the family history. CDH1 is a gene that we know is related to lobular breast cancer and stomach cancer, also called gastric cancer. So just depends on what gene it is that we find a mutation is on what the cancers that are more at risk with that mutation. We break them down into the genes that we know have the highest risks for breast cancer. Obviously, BRCA1 and BRCA2 are in this, up to an 80% lifetime risk for breast cancer. CDH1, PALB2, PTEN, STK11, and TP53 fit in that category. They've been well studied. We have very established management guidelines. We know what to do. We know what screening needs to be done and how frequently it needs to be done. So the information is pretty straightforward. We know what we need to talk about and do for the person who's detected to have a mutation in one of those genes, but then also pretty straightforward implications for the rest of their family members too, as far as what the risks are and how we would manage. The moderate risk genes, ATM and CHEK2, they're studied well. We understand them. We do have guidelines that recommend annual breast MRIs. And we base our management on the test result, but also on the family history. So we never ignore that family history. So, it may not be quite as cut and dry, and the risks that are associated with those genes change over time. We get more specific based on more populations that are studied, but still we have a good idea. And then we hit the newer genes. So our panels, the larger panels you do, the more possibly uncertain results you could identify. We have several genes listed here that we know there's limited data, but the data is supporting that there is some type of an increased risk for cancer if we carry a mutation in one of those genes, but we may not have management guidelines, or the management guidelines may have changed in time. We can still offer testing to relatives, but the impact of that testing being positive is a little bit less certain than what we would find with definitely the high risk or even the moderate risk genes. So the biggest thing, way that we determine who should have genetic testing, and we follow this quite carefully, is we call it NCCN, the abbreviation for the National Comprehensive Cancer Network. They have extensive guidelines on genetic testing, but also on the treatment protocols. And they have very good patient-directed information about treatment plans and information to share with relatives. So it's a great resource. It's free. You just have to create your own username and password to be able to get into that. It's obviously very technical, but it does have a good patient information section. A few of the things that we haven't talked about yet that would be a good reason to do genetic testing would be breast cancer that is metastatic, HER2 negative breast cancer, triple negative breast cancer, and Ashkenazi Jewish ancestry. Anytime we have a first or second degree relative, so again, if you're not quite familiar with the terms, first degree would be my parents, my siblings, and my children. Second degree, one level past that. Most of the time, these guidelines stop at about the third degree on risk level of considering for genetic testing. But if we know someone has a family history of cancer beyond that, we'll still document it and see how it compares to the guidelines. A lot of people ask about insurance, and we are not, as a profession, insurance specialists, but we absolutely do our best to look at what the guidelines are from NCCN, look at your insurance guidelines, look at the laboratories, and provide information on billing options. There are quite a few laboratories that have self-pay flat fee options for genetic testing. And some even offer free testing for relatives. If the first relative that is tested, first person tested is positive, then their close relatives could have free testing. And that window of time keeps changing between 90 and 120 days, for example. It got up to 120 days with COVID, but some labs are back down to 90 days, but still, if someone wants to do testing and they do pursue it quickly, then we may be able to get free testing for them. All right, so this is a busy slide that really the big picture is that genetic results are not black and white. They're not cut and dry. We have to really look at it in the setting of what is being tested, what gene is included, what mutation is found, if any is found, and what's the interpretation of that gene. So at the far left, we have no mutation was found, everything was negative. Just inside of that is a variant of uncertain significance, and you probably have heard that term before. That's a change in a gene that is different than the quote perfect version of that gene or the textbook version of the gene, but it's not been proven to be related to a cancer risk. And so we can have VUSs that are on the likely benign side or just undescribed. All right, everybody, here for a set of questions. The first question is, what age should genetic testing be considered when a mutation is found in a relative? This is a very, very common question that we get because a lot of us are concerned about our children. We want to be able to medically do what we can to help them if they are at risk. And we actually may have more anxiety related to that than our children do. So there's some important things to consider. Number one, the general guidelines are that we do not test children under the age of 18 for adult onset conditions. It is appropriate to test children when there's medical management guidelines that are under age 18. So not to say that it's a hard and fast rule, but it depends is the answer. There are many different factors to consider whenever we are trying to decide for a person in that 18 to 25 range to have genetic testing. And one of the biggest things for me is their ability to understand and offer consent for the testing independently from their parent or guardian. You got to think about the fact that that age range, they're under a lot of stress anyway because of college or job choices, marriage, children, however you want to look at it. You have to consider their coping skills and where they're at in their place in life. It's also important to know that the timing of when we would begin high-risk screening may not be at age 18. It may be closer to age 20 or 25. It depends on what the gene is. And so I really want to encourage people to have those discussions with their adolescent teenagers that there is a family history of cancer and there is a potential risk, but when the time is right, provide that space for discussion so that they can choose if they are ready for testing and when they are ready for testing. For somebody who is at a 50% risk, who has not had genetic testing, we can still manage them with high-risk screening. It gives us the opportunity to know they're at increased risk. It doesn't specify whether they're positive or negative at that point, but at least we can consider, doing some screening that's specific to what kind of cancer we're looking for. There's always questions about insurance and life insurance. And then another thing to consider is fertility. So if we, know that someone is at high risk for cancer, and or particularly if they have a diagnosis of cancer, we can refer them to a reproductive endocrinologist for discussion about fertility preservation, egg retrieval, however that looks specifically for them. So you can see there are a lot of factors that go into deciding to do this kind of testing. So if somebody shows up on my door on their 18th birthday and says, my parent told me I should have testing, we have a lot to discuss, and they may truly be ready to make that decision, or the right thing may be that they need to wait a little bit until they're more prepared for that personally. All right, another question, and I can't see the top of it on the screen very well, but basically my genetic testing is negative, but I am still concerned about my family history. So in this scenario, we have an unaffected person. So this could be one of your relatives or someone who comes in to the office and they have a parent or a close relative who has had cancer, and they're really concerned about their family history. So the very first thing that we do is address that question of, has the person who is related to you had genetic testing? And if they had, then let's get their records. Let's review what kind of testing they had. Is the testing sufficient? Meaning, have they had a comprehensive panel? Are we covering all of the genes that are appropriate for the type of cancer that they have? It may be that there is a family variant that's already been identified, and we can use that testing to test relatives for whatever it is. Now, if no testing has been done, or no records can be gotten, or no family variant was ever found, then we can have that next step discussion with the unaffected person of, are you ready to have genetic testing? And we go through what that involves and what kind of results can come out of it. If that testing is positive, then at that point, they have not had a diagnosis of cancer, but we have a gene that indicates a predisposition or an increased risk. So we're going to follow our gene-specific recommendations for screening at that point. If that testing is negative, then we have something that we can do that's very helpful. And that is, for breast cancer specifically, we can run a risk model called a Tyrer-Cuzick. And what this does, and we do this all the time, particularly in women who have had a relative that's had breast cancer, and that relative never had any testing, and they've just got a lot of concern about it, and they want to know if they qualify for a breast MRI. Maybe that's something that their OBGYN has brought up to them. So the Tyrer-Cuzick model is a mathematical way to be able to take the family history information along with certain personal and hormonal factors and come up with a lifetime risk of breast cancer. So some of the factors that are included would be our height and weight, our breast density, whether we have had a biopsy of our breast before and what that pathology was.